I'll start. Very good afternoon, ladies and gentlemen and friends. It's a very important free paper session, and we've got some fantastic papers actually. And I just want to know, before we start this entire free paper session, is there any presenter who's not here? Anybody who is absent can stand up. Shall I go through the presenters from 1 to 10? 1 to 5. No. No, how many? Yeah, next 5 you can announce later. Yeah. Dr. Kasturi Bhattacharjee is there. Dr. Bhavangna Bandla. Yeah, fine. Dr. Anita. Dr. Subhash Prasad, I see him here. Dr. Shah Chintan. Yes, sir. And Dr. Manish. Manish is keynote address anyway. Yeah, keynote also they have to be here, no? Dr. Sumera. Dr. Deepak Chaudhary. Dr. Abhishek. Dr. Prathisha. Shantanu Das. That's a good one. Dr. Desai. Desai is there? Desai Sanjeev? Not there. Okay, but anyway, it's the last paper. Okay, let me introduce myself. I'm Dr. Mohan Rajan. I'm the chairman for this free paper session. And along with me is Dr. Guru Prasad, Dr. Fazil, Dr. Rajiv Raman, and Dr. Pradeep Kumar. And let's get on with the first presenter, Dr. Kasturi Bhattacharjee. And she's going to talk to us on navigation guided external optic canal decompression in direct traumatic optic neuropathy. Kasturi, I think there is a time limit. Yeah.
6. Respected chairpersons and ladies and gentlemen, we all know that there are no clear guidelines available in the literature for the optimal management of traumatic optic neuropathy, where majority of the disorders are managed with customized or tailored approach. Basically, we all know that there are 2 ways of treating. One is a megadose of steroid and other is the surgical optic canal decompression. But there are so many controversies. The International Optic Nerve Trauma Study concluded that neither steroid nor surgery should be considered the standard of care for patients with traumatic optic neuropathy. The NASA study has shown very high results with high bolus dose of steroid, but the CRASH study has come down with a significant increase in the risk of death following a heavy dose of steroid. So the consensus guidelines is that traumatic optic neuropathy should be treated on individual basis, wherein we can tell the patient that we can do nothing and hope that the vision will improve, or we can try doing something and also hope that the vision will improve. When we talk about the surgery, we all know that basically there are 2 ways of doing the surgery. One is a transcranial done by the neurosurgeon, where they end up decompressing the superior one, and other is the endonasal endoscopic, where there are so many complications like the carotid artery injury, the CSF leak, and the meningitis. So we started a novel approach, a navigation-guided transcaruncular orbital optic canal decompression in direct traumatic optic neuropathy with the aim to analyze the visual outcome, the VP and OCT RNFL changes. Why the orbital approach? If we look at the diagram out here, we all know that the ophthalmic artery starts from the internal carotid artery, and as it traverses the optic canal, it moves from medial to the lateral part. So the picture to the left, it shows that towards the cranial side, the ophthalmic artery lies medial to the optic nerve, but as we go towards the laterally orbital part, it lies lateral. So the ophthalmic artery's chance of injuring is very less with this approach. And secondly, if we look to the optic canal towards the cranial side, the width of the optic canal is wider, that is 7 to 8 millimeter, whereas in the orbital side it is very narrow. So most of the strangulation occurs in this part because of the hourglass deformity of the optic canal. So second question, why navigation? We all know that the optic canal is very, very deep within the orbit, approximately 44 millimeter down within the orbit, and every optic canal is different, which has a length of 6 millimeter to 1.1 centimeter. So to reach the optic canal, you need to have a navigation system so that you can have a precise localization and go for the complete decompression. And the second thing, the navigation tells you whether you are in the distal, your mid, or in the proximal part of the optic canal, and whether you had decompressed the optic canal correctly and you have reached the targeted area. So after taking the clearance of the Medical Ethics Committee of the institution, the study included 32 patients, and it included patients who had no vision at all, non-responsive to IVMP, with a lag time of 8 hours to 8 weeks, and all examinations were done as per the prefix pro forma. And the surgery basically included here, first you mark the targeted area. Here you can see there is a fractured segment impinging the distal part of the optic canal. And once you mark the targeted area, you need to register the navigation system. And a very simple, minimally invasive procedure is done where you go by transcranial approach. And then first you make an incision and you need to expose the anterior ethmoidal blood vessels. That means you have entered 24 millimeter deep within the orbit. Go further down till you reach the posterior ethmoidal blood vessel, which is approximately 36 millimeter down within the orbit. Here we do not cauterize because it is very near the optic canal. Put the navigation system which tells you that you are in the posterior ethmoid. Go further down till you reach the optic canal. And this is the optic canal now where you see, because you see the annulus of zinc here, which has a Y-shaped structure having a superior and the inferior limb. And you need to decompress the canal out here, the superior and the medial, and then this is the optic nerve you see along with the pile blood vessels, and then you put the navigation stylet. It shows you that yes, you have reached the targeted area and you have gone for the total decompression. So the result shows that out of the 32 patients, all were male, and there are definite improvement in the amplitude and the latency of the VEP, along with good changes in the RNFL in the 3 months. And you can see that the amplitude has so much improved from less than 3, that is approximately 2 to 3.8 in the first third month, and in a year you can see that it has improved to approximately within 4. So it has shown that out of the 32 patients, 28 had bony impingement of the optic nerve, 4 had a hematoma, and 28 patients had no vision at all. And in the 1 year post-op, after doing the surgery, it was only 4 patients who remained with PL negative. And you can see that there were patients, approximately 10 patients, whose vision improved to better than 20/80. So, and also there has been changes in the pupil. As you can see, the neutral density filter has been used to see the RAPD. So this is a patient, if you look carefully, there is impinged fragments, fractured fragment impinging the distal part of the optic canal. And you can see the VP changes before, after, and a year after the surgery. The changes in the RNFL, and also this is another patient with the intracanal nerve sheath hematoma with the good changes in the VP. Another patient, we had 3 patients with a non-improvement of the vision, and to conclude that, I believe that this is a nice technique where the patient vision recovery is also possible in patient without any vision at all. Thank you very much for your patient hearing.
Now I would request Dr. Bhavna Bandla to come and speak about partial thickness scleral flap for a corneolimbar injury.
Any questions for Kasturi? Rajiv?
Any question?
One question, 1 or 2 questions.
The ones which didn't improve, did you look at any pattern in them, the people who didn't improve the vision?
Can you use the mic, Kasturi?
Nerve is within the sphenoid sinus. So most probably they were much more strangulated. One had a lateral wall fracture, and also another one had also superior wall fracture. So when we went through the why the lateral wall fracture was there, and we have gone to the previous studies, but there were no study with the orbital approach, all were done endoscopically. And they have shown that even patients, most of the patients with lateral wall fracture, they have not improved. And probably this is what I was also thinking, because the ophthalmic artery which arises from the internal artery, internal carotid artery, it from the medial to the lateral wall it goes. So there's possibility when there's a lateral wall fracture, that means the ophthalmic artery is being injured, for which there has been total ischemia, and there may be a CRA or some other changes.
Along with the optic neuropathy.
Yeah, another
Yes.
just one thing that, did the timing of intervention change your outcome? Because did you try analyzing when you did the outcome, like when was the initial injury, and correlated with the time of intervention?
Yes, sir. This is something very interesting, because textbook says that we are supposed to do within 8 hours. But these patients never come to us within 8 hours. And there are, I think the second patient, he himself is an ophthalmologist. And he came to me after 21 days. And and he had only PL vision, and I was little skeptical in touching him because he's an ophthalmologist, his parents are ophthalmologists from Ahmedabad. So I was thinking already he has got vision, but when we had done the vision, surgery, And yesterday evening, he tells me his vision today is 612 pars, and he's amblyoping in that eye with +6 -3 cylinder. So then when I have gone to the reports, there are patients where I operated after 3 months also. So now even I'm thinking that this is something interesting, like how come after till 3 months no PL, and I'm not saying wonderful improvement, but from PL negative to PL positive or PL negative to hand movement, there are only 10 patients of all these 32 patients who had some much better improvement, like 6/18, 6/24.
That's very good, actually. So, very nice.
Thank you.
Yeah.
Good evening. I'm Dr. Bhavagna. I would be presenting partial thickness scleral flap for a corneal limbal injury, a closure with a twist. Ocular trauma causes lifetime of disability in children, being an important cause of morbidity and acquired unilateral blindness. Pediatric ocular trauma accounts to 8 to 14% of total injuries in children, with annual incidence of 3.5 eye injuries per 1 lakh population between the age group of 10 to 35 years. Delayed presentation results in substantial damage to the ocular structure and thus giving poor visual outcomes. Injury leading to loss of corneal tissue can be rare, but when treated or managed with delayed outcomes can be a challenge for surgical repair. We present a 6-year-old girl from Bangladesh who presented to us 1 month post-trauma to the right eye with the edge of a tile playfully thrown at her. Initially, she complained of redness and pain, which was treated at local hospital with topical antibiotics, cycloplegics, and antifungals. She said there was symptomatic improvement in her complaints. She was further referred from her local hospital for further surgical management to a higher center. At presentation with us, her vision was 6/9 with mild anterior uveitis and no hypopyon, and 3 mm vertical corneal limbal tear with iris tissue plugged at 3 o'clock position with an exudative membrane covering it. CT orbit was done to rule out intraocular foreign body. She underwent iris reposition with corneal limbal tear suturing with 10-0 nylon black monofilament sutures under general anesthesia. Intraoperatively, after iris reposition, there was a contracted corneal tissue loss which was noticed with resulting triangular defect, which was difficult to close with direct closure. Hence, a corresponding limbal-based partial thickness flap was created as shown in this picture and flipped over the defect and sutured. Post-operative period was uneventful. This diagram shows the first post-operative picture of, with good closure and no leak. And this is 1 week post-op when the child had vision of 6/9 with good anatomical apposition. And this is 2 months post-operative visit with good apposition and mild vascularization with vision improving from 6/9 to 6/6 with minus 0.5 cylinder at 85 degrees. At 2 months post-op, she underwent suture removal. This figure shows a well-healed defect with mild vascularization. And this is anterior segment OCT showing the corneal defect well closed with the scleral tissue imbibed in it. She was prescribed glasses with 2 hours of part-time occlusion for the left eye. Coming to the discussion, defects of more than 2 mm size need grafts to close, and the common grafts that can be used are Tennant's patch graft with glue and contact lens, donor corneas, conjunctival flap, amniotic membrane, homologous sclera, and autologous sclera. But the above 5 grafts can have high chance of rejection, infection, or foreign body reaction and can heal with bad scarring. Autologous sclera, which was used in our case with a flip as described, can be giving us favorable outcomes with scleral collagen tissue having close resemblance with corneal tissue, which can be a good substitute to cover such defects compared to other tissues. The type of injury, mode of injury, the time lapse, and tissues involved of the injured eye definitely affect the surgical outcome and the visual outcome. A careful surgical examination under anesthesia and a meticulous surgical procedure is required to maintain the pupil shape and have a complete iris diaphragm. The incarcerated tissue seals the wound. With delayed surgical intervention, the iris tissue adheres to the edges of the corneal wound, which causes, on further delayed management, the contraction of the tissue and hence causing difficulty in direct closure. In children especially, vision should be monitored closely and amblyopia therapy should be initiated if necessary. Coming to the conclusion, injury leading to loss of tissue, leaving corneal defects are rare. Especially when there is delayed management and fibrosis happens, this can play as a wick for infective organisms to enter into the eye. Hence, an approach to open globe injuries needs modifying techniques from routine with innovation and thinking on the feet. Corneal tissue defects can be repaired not only with corneal grafts, but also with autologous scleral hinge grafts with good results, as in our case. Thank you.
What is the advantage of the scleral grafts or the corneal grafts? Because we use
So
corneal
she was a
defects.
6-year-old child and she was from Bangladesh. So definitely we will not have a close follow-up to monitor if there's any rejection or any other infection that is happening. When it's an autologous graft, there are less likely chances of infection or rejection that we are expecting. So
Just I missed, what was the mode of injury? How
it was a tile edge. She was playing with her brother and accidentally thrown at her.
See, how you decided that there is a defect there? Because the limbal injuries, where it's in the corneoscleral junction, usually because of the extraocular muscle pull, it gives the appearance many a times for a larger defect that there is a loss. But it may not be a true loss.
So we tried direct apposition. There was quite a bit of structural abnormality, like the cornea had quite become horizontal, and that would definitely lead to very bad astigmatism and visual outcome. So that's when we decided to do this flap.
So the defect was triangular?
Yes, sir, it was triangular as shown in the picture.
It was a full thickness defect, right?
Yes,
with
it
an
was a
iris
full
prolapse.
thickness defect with
So
iris tissue.
My concern
plaque.
is that there could be an epithelial ingrowth in course of time. Because this is from the scleral side, and you don't know, some conjunctival epithelial cells might migrate onto the flap that you have sutured, although it's a flip. In fact, because the flip, it can migrate inside.
So she had
and
come
cause
for a
an
6-month follow-up. I couldn't put in the pictures because we didn't
this
take,
is the
but
only one case you have presented.
this was one unlikely case which had come after 1 month
So
of trauma and we couldn't
you should
close.
keep that in mind. Maybe you should cauterize the sclera very superficially and
Okay.
delicately, and get rid of those epithelial cells and then suture it so that it doesn't cause epithelial ingrowth into the antechamber.
Thank you.
So the next speaker is Dr. Anita Maya. She'll be talking on, she's here? Yeah. She'll be talking on
Disclosures. As we all know, ocular trauma is one of the common causes of ocular morbidity and monocular blindness, with the reported incidence in India ranging between 1 to 5%, but it's largely underreported. Traumatic glaucoma is one such complication of ocular blunt trauma, resulting because of either obstruction or damage to the trabecular meshwork, leading to a decrease in the aqueous outflow. While in the acute stages, hyphema, traumatic uveitis, and lens injury plays a major role. Angle recession causes glaucoma to develop several months or years later. Traumatic glaucoma, sadly, is a clinically overlooked entity which can further worsen the visual prognosis in these patients. We undertook this study to determine the clinical profile, mechanisms, and course of traumatic glaucoma in 100 consecutive patients of ocular blunt trauma in our institution. This study was conducted over a 1-year period between May 2017 to April 2018, and we excluded patients who had significant polytrauma requiring intervention by other specialties. So a detailed history was obtained and a comprehensive ophthalmic evaluation was done. We defined traumatic glaucoma as any raised IOP more than 21 millimeters of mercury post a recent ocular trauma, blunt trauma, with or without glaucomatous optic neuropathy. These patients were treated medically and surgical intervention was done as and when required. We followed these patients for up to 3 months. These are the results. The demographic profile of the 100 patients are as follows. 21% of the patients belong to the age group of less than 19 years, and 56% of the patients were in the age group of 20 to 49 years. 80% of the patients were males, and right eye was the most commonly involved, and agriculture-related injuries were most common, because most of our patients belong to the rural background. 11 out of these 100 patients developed traumatic glaucoma, and this table shows the clinical profile of these patients. Now, 9 of these 11 patients were aged less than 40 years, and 6 of these patients belong to the pediatric age group with age ranging between 11 to 17 years. and 10 out of these 11 patients were males. Right eye was most commonly affected, and sports-related injuries was the most common mode. The BCVA ranged from hand movements to 6x6 parts, and the various ocular manifestations that we detected in these patients ranged from hyphema, traumatic uveitis of various grades, lens injuries, vitreous hemorrhage, and corneal tears. The IOP ranged between 26 to 60 millimeters of mercury at presentation, and most of the patients maintained their IOP with 1 or 2 anti-glaucoma medications. At 3 months, the IOP in these patients ranged between 11 to 18 millimeters of mercury, and 4 of our patients did not require any anti-glaucoma medications. 2 of the patients required surgical interventions. Patient 4, who had significant lens injury and VH, vitreous hemorrhage, went on to develop ghost cell glaucoma, at which stage our vitreoretinal surgeon intervened. He did a lensectomy, vitrectomy, followed by a scleral fixated IOL, and the patient did well after that. Patient 8, a 28-year-old male who developed a total hyphema after a road traffic accident, continued to have a persistently elevated IOP despite a paracentesis and AC wash. Ultimately, he required a trabeculectomy and did well after that. When we looked on to the possible mechanisms for traumatic glaucoma in our study, of all the possibilities, it was hyphema, which was only found to have a statistically significant association for the development of traumatic glaucoma. And although 18 of our patients were detected to have angle recession, none of them developed traumatic glaucoma during the 3-month follow-up period. Discussion. Ocular blunt trauma accounts for 40% of all the ocular injuries, and the reported incidence of glaucoma following ocular contusion ranges between 3.4% within the first 6 months and up to 10% during the 10 years of trauma. But in our study, the incidence was slightly higher, and this emphasizes the importance of serial monitoring of intraocular pressure in all patients who have sustained ocular blunt trauma. Otherwise, we would miss such cases. And most of our patients were children and young adults, and probably they developed traumatic glaucoma because of the functional immaturity of the aqueous outflow pathway in these patients. Both ocular trauma as well as traumatic glaucoma was more common in males in our study, and hyphema was the most common attributable cause. Most of our patients were well controlled with medical therapy, and 4 of them did not require any anti-glaucoma drugs at 3 months, suggesting that in many cases, traumatic glaucoma may have a self-limiting course. The limitation of our study is that it was a hospital-based study with a small sample size and a short follow-up. To obviate this, we are continuing this study to include more patients, and have decided to follow the patient for at least 1 year. To conclude, we have to serially monitor IOP in all patients who have sustained ocular blunt trauma so as to not miss traumatic glaucoma. It may occur more commonly in children and young adults, and markers like hyphema, uveitis, and lens injury can possibly predict the occurrence of glaucoma. And when traumatic glaucoma is detected early and treated, it can prevent further deterioration of the visual outcome. However, we require a study with a larger sample size and longer follow-up. Thank you.
Excellent presentation. Can you go back one slide? You attributed your traumatic glaucoma to hyphema. Rather than that, it may be the effect of the reasons which are causing the glaucoma rather than the cause. It is not imperative that once hyphema has occurred, that is going to cause the secondary changes in trabecular meshwork. The primary injury to the trabecular meshwork itself is
Maybe
mostly
a cause.
responsible to glaucoma. So using that statement in your study may be avoided.
Yes.
No, probably she meant that when you have hyphema, they have more chances of having the traumatic glaucoma. Am I right?
Yes, sir.
Or is the hyphema is not the cause of the traumatic
Not a
glaucoma.
cause,
Not
but
only
the
the
chances
cause.
of, yes, not the only
Yeah,
cause.
not the only cause. The
But it can
damage to the
predict
trabecular
that these
meshwork.
patients could have
Yeah.
IOP spikes.
Among the sports injury, did you find out what is the type of the sports?
Mostly cricket ball injuries, sir.
I thought it was more shuttlecock,
No,
which
sir.
can produce traumatic
Here
glaucoma.
they were cricketers.
Okay.
Did all the patients undergo a comprehensive examination including fundoscopy?
Yes, sir.
Did any of these patients develop a dialysis-induced retinal detachment?
In this series, no, sir.
No.
Have a patient now.
Because they can, if they have a detachment due to a dialysis, they can have a false normal
Lowering of
IOP,
yes, sir.
falsely normal IOP, which
Yes,
can, once the RD is repaired, can go up, the
For a
IOP
spike,
can
yes,
go
sir.
up.
Thank you, sir.
I'll now request Dr. Subhash Prasad to kindly come and present marsupialization, an effective technique for management of traumatic iris cyst.
ऐसे move करेंगे? Yeah. Good evening, everyone. One of the late sequelae of open globe injury involving the anterior segment is the formation of the iris cyst. It develops from the epithelial cells of the cornea or conjunctiva that have been implanted or transplanted into the iris through the wound. Once inside the anterior chamber, it can grow in a seed form or form a cyst inside the anterior chamber. The small and asymptomatic iris cyst can just be followed up, but the larger one needs surgery because it can cause a lot of problems like pupillary or secondary glaucoma, uveitis, corneal decompensation, eventually painful blind eye. There are various modalities described in literature, right from the minimally invasive aspiration of the cyst and laser therapy, or block excision involving even the base or root of the iris. Marsupialization refers to creating a surgical window in the wall of the cyst, just evacuating the contents of the cyst and maintaining continuity with between the cyst and the host cavity. The main advantage is that it is very minimally invasive and it generally does not cause too much of collateral damage. It has been used in dentigerous cyst and many others. So the aim of the study was to describe the management of post-traumatic iris cyst by cutting the cyst wall with 23-gauge vitrectomy cutter through the 2 side port incisions. This was a prospective study with 7 cases reported in 4 years' time. And all patients who had either the iris cyst obscuring the pupillary area, partly coming to the pupillary area were taken into the study. All were properly evaluated as regard their history, time of injury, nature of injury, and the history of previous repair, time since primary repair, present visual acuity, intraocular pressure, slit time examination, and the fundus examination if possible. The patients were taken into the OT once it was found to be that it was not responding to. I tried in some of the patient YAG laser, just cystostomy, but in many patients it did not work. So ultimately I thought in later on patient that it requires some kind of incision. So this is just a small video clip of a patient of this iris cyst involving 1 quadrant. Here, after making 2 paracentesis port with MBR blade, I am just injecting the viscoelastic, viscodispersive containing chondroitin sulfate and sodium hyaluronate just to separate the iris cyst from the endothelium. And then using the vitrectomy cutter, I am cutting the cyst through 1 side port and maintaining the irrigation through the another side port with the ringal VSS or ringal lactate, whatever available, using the machine of the Infinity or Centurion. This is another patient involving almost all the 4 quadrant. The patient had undergone cataract surgery also. You can see the pupillary area is also totally obscured. So after visco separation of the iris cyst from the corneal endothelium, I am again going through the side port using 23-gauge vitrectomy cutter and nibbling the anterior wall, first clearing the central pupillary area, then gradually cutting the anterior wall of the cyst all around, changing the hand in between to approach the other side. And now you can see the pupillary area has nicely been cleared, and this sheet which is there on the iris is being cut. And after cutting the maximum possible cyst, the AC was looking nearly normal, and the patient was doing well in this patient. Coming to the post-operative medication, all patients received topical steroid, antibiotic, cyclopaging, and anti-glaucoma. We are followed up next day, 1 week, 1 month, 3 months, and finally 6 months. Patching of the better eye was started after 2 weeks in patient because they all were having the risk of amblyopia. Patients were evaluated for visual acuity, IOP, status of cornea, iris, and any recurrence after the surgery. Out of 7 patients, most of the patients were young, age ranging from 3 to 15 years. Male patients were more. Their history of repair in 6 patients and the self-sealed incision in 1 patient. The corneal injury was there in 3 patients and sclerocornea in 4 patients. Time since presentation was around 6 months to 3 years, and most of the patients presented within first year of the injury. Posterior chamber IOL was implanted in 4 patients, some by me and some were operated outside, and the patient had secondary glaucoma in 3 patients. Finally, the visions improved in 6 to, the patient at the time of presentation has vision of finger count to 618. These are some of the clinical pictures. The 3 patients had 1 quadrant involvement and 1 patient had 4 quadrant involvement. Finally, the patient could, most of the patient could achieve some better vision as compared to the presentation, and one or two patients actually recovered to 612. And there was no recurrence at 6 months, but there was recurrence in a 1 year patient. This is a clinical picture of cyst involving one quadrant next day, and then after 6 months, this was the picture of the patient who was surgery I am just shown. Coming to the discussion, traditional treatment of the iris cyst is the aggressive surgical excision with and devitalization of the epithelial tissues. But there are possibility of significant collateral damage to adjacent ocular structures with resultant poor functional outcome. So there are various surgical, conservative surgical procedures reported, but they have got higher rate of recurrence. So marsupialization is a way of removing the surgical, way of making surgical window in the wall of the cyst, and removing the anterior wall of cyst probably serve the purpose of preventing collection of fluid inside the cyst and further progression. A 23 gauge vitreous cutter requires small paracentesis incision in limbus, and the cyst can be removed almost in all patients with in a very predictable and controlled manner. So there was no recurrence during the follow-up period, and only in one eye, one patient had recurrence that was in the patient with all 4 quadrants. Though my study is limited by the small sample size and very short follow-up period, and I could not have any access to imaging at that point of time, but still it gives a message that anterior wall cystectomy by vitrectomy cutter is effective and least invasive technique of surgical management of traumatic iris cyst. So thank you very much.
Very interesting. Yeah, very interesting. So, but only thing is your cutter is too close to the endothelium, I thought.
Sorry, sir. But I have always to use this viscodispersive agent so that we don't damage the corneal endothelium, sir. One has to use, without any financial interest, I use viscot in all these patients. And
so you inject viscot and separate the anterior wall from the endothelium.
Yes, yes.
And then go with the
late,
cutter.
Sir, of late what I could do that in 1 or 2 patients which I could not show the video, I have started doing the bimanual technique. I am maintaining the anterior chamber with the AC maintainer, and with the other hand using the forceps, and with one hand cutter, I am holding the tissue and then cutting. In that way, it is possible to remove even small bits of the tissue.
It's a very novel technique. Thank you for that. Could you evaluate the entire extent of the cyst by UBM or something? Did you have access to UBM? Probably you could have done a UBM to find out the entire extent of
Yes,
the cyst.
sir. That is the deficiency of my study. I agree. UBM could have
It's
been.
not a deficiency. See, you're after all describing a technique.
Actually, we don't have
The
UBM
technique is
at
really
that
good.
time in our place. So
No, it's okay. This is I mean, it's nothing to do with the study. I just was curious to know whether you found
Yeah.
out anything about the cyst extent.
I'm surprised that the recurrence rate is very less because you are leaving most of the walls there, no?
With YAG openings, there is a high recurrence rate, which I used to practice long ago. This is a very novel technique where you remove the wall of the cyst so that it doesn't reproliferate and collect again. Yeah.
and the marsupialization word has not been used anywhere. I found that. I thought that probably the same technique is being used in other cysts in body. So can we call it marsupialization or not? I am not sure, but I thought, can we give this name to this technique?
Did you ever get a bad hyphema?
No happiness.
No hyphema at all?
No, no, no.
But you suggested iris trauma at times among the complications.
Sorry, sir.
There was no hyphema.
After this cystectomy, I did not have hyphema in any patient. We could see a lot of iritis in some of the patients, but inflammation, anterior chamber inflammation, a rise in intraocular pressure, and some amount of corneal edema, but no hyphema.
Any other questions from the Rajiv? Rajiv? Huh?
This technique is extremely novel, and I think we learn from this. Thank you.
Thank you, sir.
I would request
Group.
Dr. Shahchintan. He will be talking on primary versus secondary IOL implantation in traumatic cataract after open globe injury in children.
Good evening, everyone. I have no financial conflict of interest. Ocular injury is the leading cause of visual impairment in children, and it is common in children due to unprotected and unattended playing. Mechanical ocular injury is broadly divided into open globe and the closed globe types, and the commonest cause for the reduction of vision is cataract. In closed globe injuries with cataract, primary IOL implantation is possible in almost all the cases. However, in open globe injuries, secondary IOL implantation is preferred. However, this has certain distinct disadvantages in pediatric population because multiple interventions are required under general anesthesia and the visual rehabilitation is delayed, resulting into the amblyopia. At our center, we are performing both primary and secondary IOL implantation in such cases. So the aim of the study was to compare the visual and refractive outcomes and the complications of primary versus secondary IOL implantation in open globe injury in pediatric patients. The study was a retrospective one which included 139 eyes conducted at the Sadhguru Netra Chikitsalaya from 2014 to 2017. We included patients having corneal laceration with cataract and divided into two groups. Group A being laceration repaired with primary IOL implantation in the same setting. Group B being laceration repaired followed by secondary IOL implantation. We excluded patients having zone 3 injuries or in the patients where retinal surgical intervention was performed primarily. We collected detailed demographic, pre-operative, intraoperative, and the post-operative data. Refractive errors were noted and spherical equivalent was counted 3 months post-IOL implantation, and it was considered desirable if within 2 diopters. Visual acuity was divided into these 3 grades. All the procedures were performed under general anesthesia. Corneal lacerations and the scleral lacerations were repaired with 10-0 nylon and 8-0 polylectin sutures respectively. We removed the lens matter at the time of primary repair if the anterior lens capsule was found ruptured. After this, if the visualization was adequate, then primary IOL implantation was tried by the operating surgeon. However, if the visualization was inadequate or if there are multiple complicating conditions, then the secondary IOL implantation was considered at least 4 weeks after the primary repair. Posterior capsulotomy was performed in all children under 8 years of age or those having primary posterior capsule opacification. Statistical analysis was performed using SPSS software and appropriate test was used. P-value was considered significant if it was less than 0.05. Now, 61 eyes underwent primary IOL implantation, while in 78 eyes underwent secondary IOL implantation. Trauma most commonly occurred by the wooden objects. Now, this table shows the demographic data and the preoperative evaluations. Male preponderance was seen in both the groups. Now, retrospective evaluation of data revealed better case profile in the primary IOL group, as the mean corneal wound size was lesser in the group A. In the primary IOL group, the mean wound size was 4.2 mm, while in the group B, it was 6.3 mm. Now, in both the groups, the zone 1 was the most commonly involved. Associated ocular complications, the most common one, the uveal tissue prolapse. Now, here also, the group A had better profile, and the uveal tissue prolapse and the central corneal edema was significantly less as compared to the secondary IOL group. This table compares the intraoperative and the postoperative data. IOL power calculation using keratometry from the same eye was possible in only 44% of cases in primary IOL group, while it was possible in 59% of cases in the secondary IOL group. The commonest complication was the immediate fibrinous uveitis in both the groups. In the late complications, the pupillary optic capture and the lens decentration was significantly more common in the primary IOL group. The rate of posterior capsule opacification was also higher in primary IOL group, but it was not statistically significant, while the postoperative strabismus was significantly more in the secondary IOL group. Mean base corrected visual acuity at the last follow-up was 0.42 logmar in group A and 0.47 logmar in group B. The time required for the maximum vision gain following trauma was significantly delayed in the secondary IOL group. Mean spherical error, cylindrical error, and the spherical equivalent were comparable among all the groups. This figure compares the visual acuity in pre and postoperative status. In the secondary IOL group, 47 out of 78 eyes achieved vision better than 20/40, while in the primary IOL group, 30 out of 61 eyes achieved vision better than 20/40. The management of the ocular trauma is very difficult in the children, and the most controversial questions are the timing of the cataract removal and the timing of the IOL implantation. We usually remove the lens matter at the time of repair if the anterior lens capsule is ruptured, because the retained lens matter in the AC results into the increased inflammation and raised IOP in the postoperative period. And our view is also supported by this article published in the British Journal of Ophthalmology. Primary IOL implantation is associated with certain risks like infection, inflammation, retinal detachment. Also, the IOL power calculation is less accurate because we have to take the biometry from the other eye. However, in the pediatric population, it has many advantages because the repeated general anesthesia and the multiple surgical procedures can be avoided. Rehabilitation time is significantly shortened, resulting into the better visual outcome, and it prevents amblyopia. Also, it is useful in the areas where the follow-up is very poor. In the present study, the group A cases had better profile. IOL power calculation, despite taking biometry measurements from other eye in almost half of the cases, the desirable refractive error was achieved in 66% of cases in group A and in 77% of cases in group B. Post-operatively, commonest complication was supinous uveitis, which was similar to that noted by the Baumann et al. The pupillary optic capture and lens decentration was found more common in the group A. This might be because of the slightly inferior visualization at the time of trauma repair. Posterior capsule opacification rate was very less in our study. This might be because of the higher rate of the primary posterior capsular axis in our patients. The rate of strabismus was more in the secondary IOL group. This may be because of the delayed in the vision gain. So the limitation of our studies are that it was a retrospective one, involved multiple surgeons, and the primary IOL implantation cases were less severe. So to conclude, we can achieve good and comparable outcomes with both the techniques, and primary IOL implantation may be considered in pediatric population within view of achieving early visual rehabilitation in smaller and peripheral lacerations, while secondary IOL implantations are suitable for the large extensive lacerations. Thank you.
Any questions? Good presentation. Yeah.
Just one question, see, the case selection, there was a bias, definitely between both. And it would be ideal if you had a couple of cases where visualization, a similar type of profile with both, what
Yes,
was the
sir.
outcome. Because here you are comparing, two different things.
Yes, sir.
So definitely the outcome will be, you understood my question?
Yes, sir. That's
So
a major
did you
limitation
have
in our
some-
study.
that you didn't put it as a limitable,
Yes,
that's
sir.
a main limitation.
Yes, sir.
Okay.
It's a main limitation, but it was a retrospective one, so we could not decide prior to that whether we should
No,
undergo
it-
primary
no,
IOL
no,
or the
it's not
secondary IOL.
retrospective also, if you define, you have already defined these are the criteria.
Yes, sir.
You need to see the same criteria, both the groups
Both the group. Yes,
who
sir.
are having.
Yes, sir.
And just compare that.
Yes, sir.
Still your retrospective, you can do that.
Yes, sir. That's a limitation in
And
our
how
study.
you chose who to implant primarily, that's very
Yes.
critical.
Yeah.
So
Yes,
if
sir.
you have a bad injury and the patient is not fit to be
Yes, sir.
implanted in the
I
primary
think
group,
that he has
means,
mentioned, no? You are mentioned,
That's
no?
why
that-
the case profile was better in the primary IOL group, because the primary IOL implantation was considered only in those cases where the laceration was smaller, it was peripheral, and the central visual, the visualization was adequate.
So
So
what yeah.
that's why the case profile was different in both the groups.
No, but then if you conclude that the primary was better, you are giving a wrong message.
No, sir,
then.
primary is not better. Both the groups, they were comparable in terms of the visual outcome, visual and refractive outcomes.
Now, what is your message now? You tell me whether you go for
Sir,
primary.
sir,
or secondary?
actually our hospital is in the rural setup, so majority of the patients, they don't come back to us after the trauma repair. So in such cases where our concern is to prevent the amblyopia in the pediatric population, so if we can visualize properly the capsular bag, and if we seem that the primary IOL implantation may be possible, then we can go ahead with the primary IOL implantation, because the risk that were shown in the literature. But however,
There is nothing new in that. That if you are
Yeah.
able to visualize, you go for a primary
Yes, sir.
implantation.
But the larger case series, or there is no comparative study whether we can do primary IOL implantation or rather we should wait and do the secondary IOL implantation. So in our area where the follow-up is very poor, and in the pediatric population where we are concerned with the amblyopia, so primary IOL implantation can be an option and can be considered.
Yeah, absolutely. Call the next one.
The next presenter is, I think we have a keynote address. Manish. Yeah. AIOS Rakesh Sharma Memorial Award 2018, The Claw, a novel intraocular foreign body removal forceps by none other than the Edison of AIOS, Dr. Manish Bapai.
Yeah, 10 minutes.
Good evening.
Change,
at the-
change, thing, 10 minutes. Just minute.
Good evening, everybody. At the outset, I would like to thank AIOS for conferring me with this award and giving me opportunity to present this keynote. I'll be talking about the CLAW, which is a novel intraocular foreign body forceps. We have no financial disclosures. So penetrating ocular injuries are associated with retained intraocular foreign body in significant number of patients. It is an important cause of visual morbidity and blindness in young working age population. And 3-port pars plana vitrectomy with removal of IOFB is a standard procedure for removal of intraocular foreign bodies. With the advent of small gauge vitrectomy, it has led to excellent visual and anatomical outcomes in majority of cases. However, when the foreign body is large, spherical, non-magnetic, like shotgun pellets or stones, glass foreign bodies, etc., they are difficult and challenging to remove. So this was one of the cases where the patient had a lab accident and came with a large glass foreign body, and I tried to lift it with LPFC, it would flow over it. Then I tried to make a snare or a disposable snare, and I could pick up the foreign body a couple of times, but before it could be taken out of the eye, it would fall back on the retinal surface. I had to close the case and refer it to an higher institute for further management. Later in the day, while discussing the case, my father, who's a urologist, suggested use of a device like Dormia basket that he uses when his ureteric stone removal. So initial prototype that we made was like a basket, but it was a little cumbersome, and we realized that we have to use bimanual technique to engage the foreign body. And that is when we came up with this design. It's a claw design. So this is the forceps has a titanium handle. It has a titanium handle and metallic cylinder. The metallic cylinder houses 4 prongs, which can be completely retracted within the metallic cylinder using this knob. When extended, the prongs of the claw open very wide, up to 8.5 to 9 millimeters. The prongs are made of nitinol, which has excellent shape memory and pseudo-elasticity. The outer circumference of metallic cylinder is 19 gauge, and as I already described, the prongs can be completely retracted. The distal end of the prongs, we have made them bulbous to make it little atraumatic to the retina. We can use standard methods of sterilization and reuse the forceps. Let's come to some case scenarios. In this first case is a 42-year-old male patient who had penetrating his injury with stone. At presentation, he had no perception of light, and there was scleral tear with diffuse hyphema, which was blocking the fundus view. CT scan showed a large foreign body with collapsed eyeball around it. Intraoperatively, after wound suturing and the vitrectomy, the sclerotomy was enlarged and claw was introduced, and foreign body was lifted, and it was brought to pupillary plane, while other hand was used to make a limbal section, which was almost 180 degrees, and we had to use superior rectus forceps, which was the largest instrument, to get this stone foreign body out of the eye. So this was the foreign body. It was a very large foreign body measuring 10 millimeters by 5 millimeters by 5 millimeters. This is a video contributed by Dr. Sharad Bhomaj from Sangli, where he has used this instrument. With the left hand, he enters the eye with prongs retracted, and then the stone is lifted from the it was stone foreign body which was lifted from the retinal surface, and then it was brought out from the scleral tunnel prior made with shake hand technique. This foreign body was also quite large. It was irregular foreign body measuring almost 7 millimeters. In 2016, we are all aware of the unfortunate incidents of pellet injuries in Kashmir Valley, and a large number of patients received posterior segment foreign bodies, which were pellets. These pellets vary in size from 2 millimeters to 4.5 millimeters, and they are made of lead. They are usually spherical in shape and have smooth surface, which makes it very difficult to remove them from the eye. And claw was used in these patients by my co-authors, Dr. Natarajan. This is one of his pictures where we can see the foreign body is removed from the additional sclerotomy that he has made at 12 o'clock. Since then, quite a few surgeons have used this claw for removal of glass foreign body. I personally never had an opportunity to use it, but we have used in vivo to pick up pretty large pieces from flat surface. Coming to discussion, the strength of this instrument lies with the fact that we are able to approach the foreign body in the anteroposterior direction. And as the foreign body is lying on the retinal surface in vitrectomized eye, it can shift on the retinal surface. So, the surgeon can approach the foreign body from anteroposteriorly without any bimanual technique. It can be lifted from the retinal surface. The other techniques which are available are snare. As I said, it is very good for irregular foreign bodies, but when the foreign bodies are spherical, it might be difficult to use. Macimer's diamond dusted forceps had only 2 prongs, making again spherical foreign bodies difficult. Where micro alligator forceps is a very large, needs very large sclerotomy, and it has very powerful claws which can potentially crush glass foreign bodies. So to conclude, the claw is a novel design which can securely hold and remove foreign bodies of various size, whether they are non-magnetic and non-metallic foreign bodies, and it's a valuable tool in hands of vitreoretinal surgeon who is involved in management of war zone injuries. So this is what we could achieve from not lifting a relatively small foreign body, where I could remove a very large foreign body in a trauma patient. I would like to thank Mr. Mateen Amin, who has since made these prototypes, and now the device is commercially available, and Dr. Sharad Bhomaj from Sangli for contributing to the video. Thank you for your kind attention.
Where is it available?
Sir, with Epsilon. Epsilon has it.
Manish,
Yeah.
lovely concept, as I told you last time also.
Yes.
But most of the foreign bodies are magnetic.
Yes.
Have you compared this with your intraocular magnet?
So the majority of the foreign bodies are small, they are magnetic and are not difficult to remove. This forceps is not a replacement for any magnet, not replacement for small foreign body forceps. This is that once in a, once in 2 years, 5 years, when you have that foreign body, very large foreign body, it is when, nothing else can lift it, this can lift it. The advantage is that we can insert it in the eye through a relatively small sclerotomy, 19 gauge. And then we have to, if the foreign bodies are usually large, so we have to plan the surgery and remove the lens, whether pseudophacus or whether there is a lens, we have to remove it. We can remove leave a rim of anterior capsule to implant the IOL or implant it later, but it has to come in the anterior chamber and then removed through the limbus.
Just one question, that what is the length required when, see, because if the foreign body is anteriorly placed, it's near the aura somewhere, you have very less space for the prong to open.
So in that case, for one thing, as I said, it is used after vitrectomy. We don't use it before vitrectomy.
So even after vitrectomy.
So we have to make sure that the foreign body is loosened up. And your question is very valid, because the claws open very large. Vitreoretinal surgeons are used to going close to the, going close to the object of interest and opening the forceps, like in ILM. We go close to the ILM and open the forceps. Here, we have to start opening the claws or opening the prongs as soon as you enter the sclerotomy, because they open very large. So if you go very close to the foreign body and open it, you are going to damage the retina. So you have to start opening it close to the sclerotomy and assess how much opening you need to get to grab that foreign body, sir.
Because majority of the foreign body are impacted ones.
Yes.
It will not be just going, and even if you remove the vitreous there, it will not fall
Yes,
back.
agree.
It's impacted. So what happens if it is near the aura and you are going from the sclerotomy and you start, the moment you enter, you start opening it?
Yes, sir.
No?
What happens if it's just lying very close to the macula? How do you ensure there is no injury to the macula?
So we can use LPFC in those cases.
LPFC you are to use.
Yes. So even if the foreign body is thick like this case I showed, it will not drop like a very hard and cause trauma. The fall will be slowed down by the LPFC. So trauma will not happen, sir.
Great.
Considering that the whole thing goes into the cylinder.
Yes, sir.
And comes out from the cylinder up to 8 or 9 millimeters.
Yes, sir.
Does it have the strength to hold on to a foreign body till you bring it up to the...
So as I showed with that stone.
If the foreign body is heavy and if it is hard.
Yes, sir, it has. Actually, see, as I described, the prongs are made of nitinol and they have pseudo-elasticity and good shape memory. So even if they deform a little, the prongs open up to 9 millimeters to 9.5 millimeters. But we can easily hold foreign bodies up to 12 to 13 millimeters, because those prongs can regain their shape. 12 to 13 millimeters? Yes, sir. The foreign body that I removed was almost that big. Yeah. And secondly, Dr. Shanmugam's group has shown video in one of the meetings where they have used it for removal of very hard nuclei which are very hard. You can pick them up in one hand, and with other hand you can use fragmatome and take it and remove it. So that is another useful scenario where we can use this.
Or you can even bring the nucleus up into the anterior chamber.
Yeah, yeah, absolutely. So with the treatment of choice remains yours. Is it something
We've
to grab?
actually had some experience with this foreign body, the pellet removal
Yes,
from the posterior segment. And most of the times, it comes out through the scleral wound also.
Yes.
You have to extend it a little bit. And before that, we have tried many things. Because when pellet injuries became common in Kashmir, we had little experience with them. And these were lead pellets.
yes.
And the size would be anything around 3.5, 4, unpredictable. Different pellet guns had different size pellets. So before this instrument reached Srinagar, actually there was a lot of struggle. Aruga's forceps and some people also used a Calazion scoop to hold on, hold the pellet on and bring it anteriorly after a lensectomy. Wonderful presentation.
Very nice.
Thank you very much.
Thank you, sir.
I would now request Dr. Samira Zargar. This is a best paper from J&K Ophthalmological Society, a retrospective study of severe ocular trauma.
Good evening, everyone. I'm Dr. Samira from Srinagar. I'll be presenting a study on retrospective ocular trauma, its clinical features, presentation, and its effect on final visual acuity. So as we know, ocular trauma constitutes an important cause of preventable visual morbidity worldwide. It's one of the main causes of severe ocular morbidity. Globally, more than 55 million eye injuries occur per year, and there are approximately 1.6 million people with blindness from ocular trauma. Kashmir is a disturbed state, as we know, and incidences of violence have markedly increased in recent years, which have resulted in an increase in severe ocular trauma. The objective of this study was to know the characteristics, presentation, and the final visual outcome of patients admitted with severe ocular trauma. So the patients with, this study was done in Skims Medical College, where patients were reviewed retrospectively from March 2017 to 18. Age, gender, affected eye, causes, types of ocular trauma, time interval from the injury to presentation, duration of hospitalization and follow-up were recorded. Management and final visual acuity were also documented. Ocular trauma was classified by the standardized international classification of ocular trauma, that is Birmingham Eye Trauma Terminology System. Statistical analysis was performed by SPS version. This study included 92 patients. Ocular trauma treated on outpatient basis were excluded. Males had a higher incidence. The largest age group involved was between 11 and 30 years, depicting the age group which is most vulnerable to trauma in disturbed states, showing the largest age group, 11 to 12 being the most, and followed by 21 to 30 years. 37 patients had injury in the right, while as 55 patients had in left. 80.5% patients presented within first 24 hours after the injury, while only 13.6 presented after more than 4 days. Average duration of hospitalization was 6 days. Our study revealed that the closed globe injury was the most common presentation with full chamber hyphema and vitreous hemorrhage. Open globe injury accounted for 30% of cases, with cases of rupture, penetrating or perforating and intraocular foreign bodies. 10 eyes had adnexal injuries also. 41 patients had pellet injuries and injuries due to stone pelting. Other cases include burn trauma, RTAs, and animal bites. This is a mode of injury showing the pellet injuries trauma, the most important cause, common cause. In terms of management, 43 patients were treated conservatively, while the rest required surgical intervention. Only 24% of eyes had initial visual acuity of 6/18 or better. 10% had hand movements, or 3% presented with no perception of light. The patients, after 6 months of follow-up, showed 6/18 or better in 26.1% of cases, 6/24 to 6/16, 19.9% of cases, and hand movements in 21%, and no perception of light in 4.7%. There was a significant correlation between the initial and final visual acuity. The limitations of this study being the number of injured eye might be underestimated because some closed globe injuries might be treated as outpatient and the sample size was small. And second, during the study period, the incidences of violence were relatively less. My conclusion is the susceptible population of eye injuries where young age groups and proportion of males was higher. The leading two types of ocular trauma were violence related and work related. Initial visual acuity was a significant predictor of the final visual acuity. It is worrisome that none of the admitted patients used protective devices at the time of injury, and prevention of eye injuries requires education of children as well as their caregivers, and the pellet guns should also be used judicially. It's also recommended that efforts should be invested in education for eye protection in order to prevent ocular trauma in young and middle age group. Thank you.
Any questions? For the panelists, any questions?
Any particular part of the body was injured other than the eye?
If a patient had multiple pellet injuries, the most common part of the body was above the chest. So they received multiple pellet injuries on the chest area and the face as a whole.
So actually, when the pellet gun is fired, there is a trajectory. It spreads out like this. So two things determine
How many pellets come out?
There are hundreds of pellets in one shot.
In one shot. So the injury is related to the distance at which the pellet gun is fired. So closer it is, we've seen cases varying from just a subconjunctival hemorrhage to a subtenon's pellet to something like a blunt trauma and otherwise a through and through entry and exit up to the optic nerve and intracranial pellets. But that's very short distance. Otherwise, it has been classified as a non-lethal weapon. But where the eye is concerned, it's a catastrophe.
Yes. But to say it goes back up to the orbit, it can go up to the brain also.
Yeah, we have seen two cases where the pellet was in the brain.
I think very good paper, but the last conclusions where you are telling about protective eyewear, I think more important is what sir is telling, is banning of the device or having some regulation rather than talking about.
Yes, sir. Yes, sir. That should be there.
You cannot ask that people wear a protective glass.
They actually do.
They actually do. Thank you, sir. Thank you so much.
They should wear a helmet as well, always. Yeah, we call the next speaker Dr. Deepak Chaudhary, and on ocular injuries due to blouse hook in babies and their management.
Good evening, everyone. I am Dr. Deepak Chaudhary, and my AIOC registration number is C20269. Today I am presenting ocular injuries due to blouse hook in babies and their management. I have no financial interest. Introduction. Injury by blouse hook fasteners is unique to infants in the Indian context. Canalicular association is one of the common injuries seen in the pediatric age group. Majority of them are caused by maternal blouse hook in breastfed infants. If mothers were not aware about these injuries, the injury requires prompt surgical correction by an ophthalmologist, and poorly repaired wounds or unpaid wounds run the risk of persistent epiphora in these patients. This injury can be prevented to some extent if you can incorporate ocular safety counseling to mothers along with breastfeeding counseling during the postpartum period. Aim of our study is to study ocular injuries due to blouse hook in babies during breastfeeding. Metal method. The study included 22 eyes of 22 babies with ocular injuries due to blouse hook. It was a prospective interventional case series for 1 year duration. It is done from November 2016 to October 2017. Inclusion criteria are all babies suffering from ocular trauma due to blouse hook during breastfeeding, and the exclusion criteria are eyelid injuries of babies due to other causes, and if the baby has associated facial injuries. In this patient, detailed ophthalmological investigations were carried out, and patients with full thickness eyelid injuries were admitted, and rest patients were managed conservatively. All patients with full thickness lid injury were subjected to routine investigations, and full thickness eyelid injuries were repaired in 3 layers under general anesthesia using 60 Vicryl and 50 silk sessions. The canalicular injury repair was done whenever possible. We have used 24 number Benplon cannula for canalicular repair due to unavailability of the mini monogastrants, and as our institute is a government institution and most of the patients were poor, they cannot afford to buy a mini monogastrant or oral lacrimal stent. Follow-up examination was done at 1, 4 and 6 weeks, and cannula was removed after 6 weeks following repair. Results: 20 eyes of 20 views with ocular injuries due to blast hook were studied. 15 patients, 68.2% were male and 31.8% were female. Youngest was 10 months old and oldest was 3 years. And corneal abrasion was found in 54.6% cases, and 18.2% cases had subconjunctival hemorrhage, and full thickness eye injury was reported in 9 cases. Out of 9 cases, 7 cases at 77.8% had lower lid laceration with canalicular injury, and 2 had laceration in the lateral canthal area. 5 cases were repaired with 24 gauge Venplon cannula, and other 2 cases only lid was repaired. As they came lately, and the presentation was late, and there was gross edema, so we only repaired the lids, and we could not repair the canaliculi. And out of 5 cases, after 6 months, only 2 cases, there 40% had patent canaliculi. And in the table showing corneal abrasion 54.6% cases, and subconjunctival hemorrhage in 18.2%, lower canalicular injury 31.8%, and lateral canthal injury is 9.1%. This is the picture. Discussion. Nayak et al. In 66 patients with eyelid laceration found 36 cases had involvement of canalicular system. The mode of injury included biologic fasteners in 20.8% of cases. Lower canal was involved in 54.1%, and in 33.3% cases, and upper in 33.3%, and in both in 12.5% cases. 27 cases, 27 canalicular ascension of 25 patients, they underwent stenting with mini monoga stent. But in our study, 31.8% cases led canalicular injury, and 71.4% were repaired with 24 number Venplon cannula. And Gupta et al. Also in a study in 13% of canalicular tear found mother's blau is the culprit. It is a unique case of canalicular laceration peculiar to Indian scenario. Conclusion: to avoid such injury, proper precautions to be taken during breastfeeding must be taught to every mother by pediatricians and health workers, and proper treatment of injuries should be done by ophthalmologists in babies with ocular injuries. After this study, we have organized awareness program in pediatricians and pediatrics nursing staffs, and we educated them about the importance of this trauma scenario, and they were advised to educate each and every female means mother during breastfeeding. They should use hookless means blouse or means plain dress to avoid such type of trauma. Thank you.
I think it's a very important problem which you have to think always, especially when they are breastfeeding and.
Yes.
Yeah, I've had a couple of patients wherein the babies have had, because of the pin sometimes, sometimes they have safety pin in the blouse.
Yes.
That is injured, produces even a corneal tear.
Yes.
So, any comments?
So we are planning to organize this kind of awareness program every month, including obstetric and gynecology people and pediatrics, doctors and nursing staffs and health workers. And we will gradually organize in the district levels also. through CMEs.
Can call the next.
Yes, sir, it may cause facial injuries and the angle of the mouth. Some patients during the they close the baby's head with saris and they observe it after feeding. And when the baby cries, they look for eye injuries and the mouth injuries.
Okay, I think we are running short of time. I request GP to call the next.
The next paper is Traumatic Macular Hole, New Insights About Outcome of Vitrectomy in a Small Case Series by Dr. Abhishek Anand.
Hello everyone, I am Dr. Abhishek Anand and I will be speaking on traumatic macular holes. We have currently done, we are 2 operating surgeons and I am presenting my data, which is of 7 cases. So we all know that the first 2 reports by macular hole were NAP and NOIS, and these were not surprisingly about traumatic macular holes. However, as we have evolved in our study, our understanding of idiopathic macular hole, our study and understanding of traumatic macular hole has lagged behind. It has lagged behind in how much visual outcome it can achieve, success rates, appropriate time of intervention, surgical techniques, frequent association with pediatric age group. So that is a big question mark, and chronicity. Coexisting ocular morbidity also is a big concern, like chorioretinal rupture, scar, subretinal hemorrhage, and RP atrophy. So aim of the study was to assess the spectrum of TMH responsive to PPV with standard ILM peeling, inverted ILM flap, and assess the role of inverted ILM flap as a treatment option for large traumatic macular holes as well as chronic macular holes. So this was this study includes 7 eyes of 7 patients with traumatic macular hole, and then 2 eyes were subjected to complete eye examination. We are also doing SDOCT measurement with, but since we have no meaningful statistical, this is a small case series, so when we talk to our statistician, no meaningful statistical interference can be drawn, and we will certainly come out when we have our case series increase. So the inclusion criteria was very simple. Any traumatic macular hole, irrespective of what condition at chronicity, we are going to include it and we are going to intervene. The operative procedure was inverted ILM flap. I am doing a petalloid inverted ILM flap, while my other surgeon is doing a temporal ILM flap. The follow-up visits were 1, 3, and 6 months, and in every visit, full ophthalmic examination was as well as SDOCT measurements were taken. The study includes 7 eyes, 4 left and 3 right of 7 patients, and not surprising, 5 male and 2 females with traumatic macular. The age of the included patient ranged from 6 years to 35 years with a mean of 17.43 years. Time elapsed from the result of trauma, and that is very surprising that we did a macular TMH which was around 36 months and with a mean of 8.14, and as you can see, because of a small case series, we have a very high standard deviation. There was one case which was intervened at 1 month because the patient also had an accompanying subtotal nasal retinal detachment. Now, regarding traumatic macular holes, we have encountered there were 7 patients, and 1 was with stone injury, 2 with cricket ball, and 1 was with fist injury. And now I would also like to emphasize, like I belong from Bihar, and this rubber band that is used for tying large loads behind your motorcycles or cycle. This is a very common etiology for trauma. So rubber band is we're 3. And we in case 2, 3, and 4, and 7, we had coexisting morbidities which could have affected the outcome of the results. Now, when you see over the base diameter, which is a very important predictor of how your macular holes will respond, then we had a fairly high, it's on the very high range. Only one which was less than 1,000, which was around 776 microns. Regarding when we had our success rate, we have out of the 7 eyes, 6 eyes we got a complete anatomical closure, while in 1 eye we couldn't achieve the anatomical closures. Regarding the 6 eyes, we had 2 eyes which we achieved type 1 closure, while in 4 eyes we achieved a type 2 closure. So these are the 6 eyes in which our traumatic macular hole closed. There are some interesting findings, and I would just like to see you with, this is a case, second case, and you can see there is a subretinal hemorrhage, and the base diameter was 1009 micron, and we could achieve it, but this patient also had a traumatic mydriasis, so the final visual acuity was not that good. Now this case is very interesting. I would not have intervened, but this patient and mother were insistent on operating me. After such a long time, we have a large subretinal scar, which is elevating the edges. What is important to note that we could But just what is bridging the gap is the inverted ILM flap, and this is obviously a nasal ILM flap. What is most important is that the edges, if the elevation from the RP, it has decreased if you look at the two sides. So that is important. And these are the pre-op and the post-op SDOCT, and you can see the ILM flap is completely bridging the flap. Even in this case, the patient did give an improvement of vision. This was the fourth case, and in this case, we had a subtotal retinal detachment, which was also present on the cases. So we had to intervene only at first 1 month, and this patient, what is important is that this also shows the technique that I used, and can I forward it? Like, no. So as like standard procedure, we used to stain the vitreous gel. So in this case, there was no cortical vitreous present. I extended it to as periphery as possible with my cuirass, and then we could complete the vitrectomy. After completing the peripheral vitrectomy, we stained this was the pre-operative nodal break. So, and then we stained it with, this is a Reti blue and this is not OQ-blue G. And we then, after looking, we are really looking for any cortical vitreous remnants, which we couldn't find. And then as a standard petuloid fashion, we do it 360-degree ILM peeling and then fashion the ILM flap with a high cutting rate and low with a vitrectomy cutter and low aspiration. So, and then we just close it. We don't stuff the ILM flap inside the hole or anything like that. And we could get a good closure in this. I wanted to show was that even in the periphery, which I missed, there were a lot of small atrophic holes in the attached retina. So that was one thing that I noticed in this case. So this is a sixth case in which we can see clearly this is an old 3, all the changes that are typical of a chronicity are present there, and even in this we could achieve closure. This was the seventh case in which we couldn't achieve closure, but if you see the minimal linear diameter has decreased from 554 micron. I feel that in this case when the patient came first for the first follow-up, the patient didn't maintain the position, and because there was C3F8 bubble present in the anterior chamber itself. So basically I wanted to say that we all wait for 3 months in traumatic macular holes, and we had a relatively large traumatic macular hole size with base diameter ranging from 76 micron to 3045 micron. And this small case we could achieve positive functional gain even in very old TMHs. Our success rate and anatomical closure rate is almost comparable with the literatures, and the post-operative visual acuity in the operating eye is improved in all eyes. To conclude, positive outcomes can be achieved in traumatic macular holes despite coexisting comorbidities, chronicity, and large time lapse before intervention. Early to say, but OCT biomarkers for TMH may not be good predictors of surgical outcome. Thank you.
First of all, excellent surgical videos. 2 observations. One, what you were doing in inverted ILM flap, which you had stained with your trypan blue, if I am correct. You were using a combined flap of epiretinal membrane and ILM. Though it has been described, but when you are submitting it for publication, people might ask you this. So this is not a pure ILM flap technique that you have used. Secondly, the few of the cases that you showed, there was type 2 closure. And one of the cases was under oil, if I see it correctly.
Yeah.
So what was your reason for putting oil in such cases?
So that case has a subtotal retinal detachment.
Okay.
Nasal subtotal retinal detachment also was present. And the video in which I showed that patient had a nasal subretinal detachment.
Yes.
And there were multiple atrophic holes. I would have preferred gas, but then there were multiple atrophic holes all around the aura. So in that case, I thought might be it's better to go for oil. It's obviously we can go for very safe for go C3F8 also.
A small sample size, but best of luck for the larger series.
Thank you.
Now I welcome Dr. Pathvi Shah to give her keynote address on eye in nose, a bullhorn injury. I stand corrected. It's not a keynote address. It's a paper with a non-ratified member.
Yeah, it's not a keynote address. It's not a.
Good evening, everyone. My AIOS membership number is P21526. I knows a bull-on injury, as absurd as it sounds. Well, a 68-year-old female presented to the casualty of a tertiary care hospital with a chief complaint of sudden and painful dimness vision in the right eye following a bull's-horn injury 1 hour back. There was some pain and bleeding in the right-sided periorbital region. Otherwise, the patient was vitally stable. On examination, this is what we found: an empty socket. She had perception of light with conjunctival chemosis, mechanical ptosis, and surrounding lid edema. There was a contused lacerated wound over the eyebrow and the inferior orbital rim. On examination, she had a perception of light in that particular eye. Otherwise, the left eye was normal. A primary management was given, and we further took up the patient for investigations like B-scan and a plain CT head and orbit. The B-scan revealed the right eye to be present, but it was inferiorly displaced from its original position. The lens was seen in situ and the axial length was normal. There was no perforation. Left eye was normal. And in the CT scan, they revealed that there was a posterior, infero, and medial displacement of the right eyeball, with its medial portion lying in the anterior ethmoidal sinus. Literally, the eye was in the nose. Separate muscles could not be identified with surrounding contusion present. Also, we could see the attachment of the optic nerve with the globe, and there was a comminuted displaced fracture in medial wall of the right orbit involving the anteromedial aspect of the floor of the orbit. A combined management with the ENT colleagues and ophthalmologists was done, and the patient was posted under general anesthesia for repositioning the eyeball under endoscopic guidance. Endoscopically, the eyeball was located and pushed from the nasal cavity in upward and outward direction and simultaneously pulled into the orbital cavity with the help of the muscles. Support was given to the eyeball with absorbable gelatin sponge. Intra-op findings showed this was at the start of the surgery, and this is what we ended with. The globe was intact with no perforations. The conjunctiva was chemosed with multiple tears. Cornea appeared to be clear with a few abrasions. Individual muscles could not be identified clearly. The pupil was circular, 3 mm dilated, not reacting to light, and an immature senile cataract was observed. A first post-operative day, the patient was giving a vision of counting finger 1.5 meters for distance with a near vision of N18. There was enophthalmos, exotropia, and restriction of movements. The pupil showed the same kind of scenario, and an immature cataract was seen. Ocular movements were restricted, both uniocular and binocular. A dilated fundus examination was done on first day post-operative, which showed a normal fundus, absolutely normal fundus. The patient was given the following treatment and was then discharged after a week. First week post-operatively, the vision improved to 6/60 for distance. The patient had enophthalmos, exotropia, and restriction of movements. And at 1 month follow-up, the visual acuity was nearly by 6/24 for distance and N18 for near. There was slight reduction in the ptosis with an exotropia of 35 prism diopters. Pupil was absolutely normal, central, and reacting to light, and there was no complaint of diplopia. Subsequent follow-up showed a visual acuity of 6/18 for distance and N18 for near, which can be attributed to the immature senile cataract. Examination revealed slight reduction in the ptosis, but exotropia of 35 prism diopters and restriction of all ocular movements, especially adduction and elevation, persisted. Pupil became central and normal, reacting to light. Symptomatically, patient was much better with no complaint of diplopia. This is a rare case of a variant of blowout fracture presenting with the eyeball displaced into the ethmoidal sinus, in which the patient thereafter regained vision in the affected eye. Thank you.
Very good. Nice one. Shall we go on to the next speaker? Any questions for Dr. Pathvi? Rajiv? Good. Okay. We go on to methodology of the choice of orbital implants in the management of orbital fractures. Dr. Shantanu Das. What about Dr. Desai? Sanjeev is not there, no? Dr. Desai, Sanjeev. Okay, the last.
Good evening, everyone. I'm Shantanu Das, and I'll be presenting a paper on methodology of choice of orbital implants in the management of orbital fractures. Orbital fractures are common and constitute approximately 18 to 50% of all the craniomaxillary fractures, depending upon region. There has been a debate regarding the timing of the surgery, but also regarding the best possible implant available for reconstructing the orbit. So what are the properties we are looking for in an orbital implant? The ability to bend into the proper anatomical shape, radio opacity, permanent stability, and biocompatibility. 35 patients with confirmed orbital fractures on CT were included. It's a prospective study from January 2017 to June 2018. A thorough ophthalmic evaluation was done for all the patients. CT scan of the orbit were done in relevant cases. Isolated medial wall fractures, lateral wall fractures, roof fractures with no functional deficits were not included in this study. Patients were followed up at 1 week, 1 month, 3 months, and 1 year post-surgery. They were divided into 3 groups. Group 1, type 1 fracture, that is one wall fracture with a displacement less than 1 centimeter square. Type 2 fractures where there is more than one wall fracture with displacement of 1 to 2 centimeters square, and type 3 fracture where there is a orbital wall fracture as well as other facial bone fractures and displacement of greater than 2 centimeters square. So all type 2 and type 3 orbital fractures, that were 28 patients, were repaired using the titanium mesh, and type 1 orbital fractures, there were 7 patients, were repaired using the porous polyethylene implant. So this is a patient with a type 1 fracture, inferior wall fracture, and there is a superior gaze restriction. FDT is being done before the surgery. The porous polyethylene implant is being shaped as per the size of the orbit, and finally the porous polyethylene implant is being placed inside the orbital cavity. Secondly, this is a type 2 orbital fracture with an inferior wall fracture as well as a lateral wall fracture and a ZMC fracture. So here the titanium implant is being molded to form the posterior-medial bulge, and it is being fixed to the inferior orbital rim using a 6-hole orbital plate. And finally, the titanium implant is being placed into the orbital cavity and again fixed onto the inferior orbital rim with a orbital plate. Post-operative outcome with titanium mesh, this patient presented to us with an inferior wall fracture, lateral wall fracture, as well as a ZMC fracture. So here the ZMC fracture has been reduced, then the titanium implant has been placed in the orbital cavity, and this is the final outcome that we have achieved 1 year post-surgery, good cosmesis as well as good visual outcome. Post-op with porous polyethylene implant, this patient had a small inferior wall fracture with a superior gaze restriction. We used porous polyethylene implant into the orbital cavity, and this is the outcome we got 1 year post-surgery, good cosmesis again with very less scarring. Post-operative outcomes, there were no incidents of implant-related hypersensitivity reactions or infections. There were no incidents of implant extrusion either in the immediate post-operative period or 1 year post-surgery. There were no incidents of implant removal or implant-related functional deficits like motility restriction or drop in vision from the preoperative period. Discussion: the advantages of prefabricated titanium implants are its availability, stability. The most important thing is the contouring. It can be contoured as per the posterior medial bulge can be formed. The radio opacity allows dissipation of fluids. There is no donor site. The disadvantage, it can't be used in children, and even if you use it in children, it has to be removed after 2 years to allow proper growth of the orbital cavity. Porous polyethylene implants has its own advantages. It allows very good tissue ingrowth. It has smooth edges, availability. Disadvantage, it is not radio opaque like a titanium implant, and it can't be molded like a titanium implant, so it can't be used for more than a 2-wall fracture or 3-wall fractures. One more implant is the composite implant. It has the advantages of both the titanium and the porous polyethylene implant, but the disadvantage is there are reports of post-operative implant migration, infection, and diplopia, and there is less drainage from the orbit. So this study tells us that porous polyethylene implants can be used safely in orbital floor fractures without any post-operative complications. This review article tells us that titanium implant is best because of its contouring property and because it gives us very good stability in large fractures where more than 3 walls of the orbits are involved. So conclusion, From our study, we conclude that both the types of implant are safe and biocompatible for reconstructing orbital fractures. Titanium is cost effective and gives good contouring and rigidity in large fractures, whereas porous polyethylene contouring is difficult and also has less rigidity, but can be used effectively to treat small floor fractures. Thank you.
Anything new you have found out this?
No, in this, what is the thing is that, I mean, basically when the fracture is large, we have used a titanium implant. I mean, porous polyethylene, though it has some advantages like a very good tissue ingrowth it allows, then it has got smooth edges, but it can't be used for more than, I mean, one wall fracture, because when we try to contour it, it breaks. So titanium implant in that case is very good, and also titanium implant cost-wise it is also less, and in our setup, I mean, the kind of patients that we get, I mean, it's much more affordable for them. And we have divided the patients into 3 groups: type 1 fracture, type 2 fracture, and type 3 fractures.
What is the cost difference?
Cost difference, I mean, one titanium implant will cost you around 3,500. Whereas porous polyethylene, I mean, if the patient wants to buy a new one, it costs them around 10,000. So, yeah, difference is there.
I think with this we come to the end of the session. It was a very good session. All the speakers were really fantastic, and the content of the scientific content was very good. The way they presented also, it was very nice. So it's going to be very difficult for the judges to find out who is going to be the winner. All the best.